Hi students, myself Dr. Keshivaya, Department of Pharmacology, Shantiram College of Pharmacy, India. So hope I think all of you well. So already we discussed about immunology and immunosuppressant drugs. So few more drugs are pending regarding immunosuppressant drugs. We can discuss about these. So sirolimus, I think this one also we discussed already. Is a sirolimus, is a brand name is a rapamycin. We heard somewhere rapamycin, where it is. That is mammalian target of rapamycin, MTOR. See the MTOR. See, already I given one diagram in first video and second video. So in signal, third signal, interleukin, when it is binded to the receptor, then it activates the MT or mammalian target of rapamycin. These mammalian target of rapamycin, what is the function? Increases the translation of selected mRNAs that promotes a transition from G1 to S phase, G1 to S phase of the cell cycle. So cell proliferation regulated by the MTOR, mammalian target of rapamycin, mammalian target of rapamycin. Okay, it is a protein. So to enhance the proliferation, understood? So here the sirolimus. So why I'm talking about rapamycin? They given the brand name rapamycin. So that's why once again I remember the MTOR. That's all. Fine. Here these sirolimus drugs. This sirolimus drug is a trained macrolide antibiotic. Trained macrolide from it is obtained from Streptomyces hygroscopicus from Easter Island. So the mechanism of action of this binds to, that is FK binding protein, F12 complex. Already I explained in the second video what is the role of the FK binding protein 12 and complex inhibits the target of rapamycin and interleukin 2. Driver means the productivity. So when it is lost, there is no T cell proliferation. Got it? So arresting the cell cycle in the G1 phase, it is will not enter to the G1 to S phase. Just now only we discussed about the role of the MTOR. If the interleukin it is not produced, the interleukin not bind to the signal 3, but I given, so that interleukin 3 when it is not binded to the in third signal, that MTOR not produced, the MTOR not initiating the or not regulating the G1 to S phase. Nothing but a translation process, other transcription process. So that is about a sirolimus. And then if you observe the side effects, these are the side effects: hyperlipidemia, increased toxicity of calcineurin inhibitors, thrombocytopenia. So whatever the earlier we discussed, the calcineurin inhibitors, whatever the side effects is there, all that side effects. That is thrombocytopenia, mouth ulcers, pneumonitis, intestinal lung disease, interstitial lung disease, lipid monitoring required. So these are the side effects. So recipients whose risk of rejection is low to moderate can stop cyclosporin treatment to 4 months after transplantation. So these are the regarding about side effects. So when that time, if you're not stop the cyclosporin, then that time we can give the sirolimus. So that's given the explanation. It is not that much required in the side effects. So it's better to write these side effects up to 6. Next, come to the drug azithromycin. So this one of the brand name is Immuron. That's why it is given. So immunosuppressive antimetabolite, already we studied in anti-cancer. Hope I think understand. Is available in the tablet form for oral administration and 100 mg vials for intravenous injection. So both it is available. So prodrug that release so it is a prodrug. Azithromycin is a prodrug. It releases the 6-mercaptopurine. What is the role? What is the role of a 6-mercaptopurine in the anti-cancer? So the first immunosuppressive agent to achieve the widespread use in organ transplantation. It is widely used in organ transplantation mechanism. It inhibits the purine synthesis. The mechanism of action is it inhibits the purine synthesis, inhibiting the proliferation of cells, especially leukocyte. This is the main mechanism of action of the azithromycin after converted into 6-mercaptopurine. Already we studied in anti-cancer drugs, 6-mercaptopurine purine antagonist, or inhibition of purine synthesis. So convert 6-mercaptopurine to tissue inhibitor of metalloproteinase, which 6-mercaptopurine tissue 6-mercaptopurine is a tissue inhibitor of metalloproteinase, which is converted into thioguanine nucleotides that interfere with the DNA synthesis. So thioguanine derivative may inhibit purine synthesis, prevents the mitosis and proliferation of rapidly dividing cells such as activated B cell and T lymphocytes. So here, we can observe here the azithromycin, when it is converted into, it is a prodrug when it is after conversion of 6-mercaptopurine. So it is metabolized by two enzymes, that is thioprin's X-methyl transferase enzyme and xanthine oxidase. When it is these enzyme more, it is inactive form. It is in inactive form. But when it is converted into thiosin monophosphate in the presence of these enzyme, when it is converted into thiosin monophosphate, then after that thiosin monophosphate, it is to form when it is thiosin monophosphate, it inhibits the de novo purine synthesis. So what I discussed here, that it is converted into, so after so how it is converted, that is thiosin monophosphate is converted into thioguanine derivatives. So these thioguanine derivatives may inhibit purine synthesis. So when it is purine synthesis inhibited, then the DNA synthesis stop. So one more time, when it is the thiosin monophosphate is also in the presence of these enzymes, it is converted into 6 thio something as the derivative it will come. These derivative also incorporated into DNA. So this one also DNA synthesis inhibited. So this is the how the azithromycin involved in the cell proliferation. Okay. So when it is prescribed, these azithromycin prescribed for FDA, so Food and Drug Administration, renal homotransplantation, when it is any kidney or other transplantation, when it is give, during that time we can prescribe azithromycin. And rheumatoid arthritis, treatment of active rheumatoid arthritis also. Rheumatoid arthritis is autoimmune disorder disease. That's why we have to suppress the immune system. That's why during that time also we can give the azithromycin. So non-FDA, multiple sclerosis, Crohn's disease, myasthenia gravis, and Crohn's ulcerative colitis, and autoimmune hepatitis. So and the side effects of these drugs is leukopenia, bone marrow depression, macrocytosis, liver toxicity, and blood count monitoring required. So this is always in all immunosuppressant drugs it is required. Next drug is mycophenolate. So another drug, mycophenolate is a safety and efficacy in prolonging graft survival It has been successfully used in a heart and kidney and liver transplant. It is mainly used in when it is heart and kidney and liver transplant. Already we discussed about why we have to use it in the especially in a transplantation, because of your immunity system always reject the foreign materials, nothing but the whatever it is a protein or it is an organ, but it is a microorganism. So that we have to inhibit the immunity. So that's time we can give these immunosuppressants. So especially in the heart and kidney and liver transplantation, we can give the mycophenolate drug. So what is the these drug mechanism of action? So inosine monophosphate is converted into xanthosine monophosphate. This xanthosine monophosphate converted into guanine monophosphate. Guanine. This the guanine monophosphate due to rapidly proliferating T cell and B cells. So guanosine monophosphate, the role of the guanosine monophosphate is the rapidly proliferation of T cells and B cells. When the T cells, B cells, when it is more produces in the body, the it's nothing but immunity developed, either antibodies developed or T cells, that is nothing but T killer cells are developed. When the T killer cells are more developed to kill the whatever the foreign material, so that we have to inhibit the T and B cells. So that's why we can give the mycophenolate drug to conversion of inosine monophosphate to xanthosine monophosphate. So there is no, then after that there is no formation of guanosine monophosphate. So there is no proliferating T and B cells for this synthesis. So this is the role of the mycophenolate. So rapidly produce is a key component of nucleic acids. Okay, next. So it is a oral and injection, and both is available, and describes the mycophenolic and from acid from penicillium molds. We can obtain this in the penicillium molds. So mechanically inhibit the synthesis of inosine monophosphate dehydrogenase, block the Purine synthesis, preventing the proliferation of T and B cells. So this is the diagrammic representation of how it is inhibited. Suppose if you observe here the 5-phosphoribosyl 1-phosphate is converted to inosine monophosphate. Inosine monophosphate is the synthesis of urine, that is a guanosine monophosphate. Guanosine monophosphate is used in guanosine monophosphate to form the guanine. This guanine, it is enter into the G2 and M phase, then it is utilized for the DNA synthesis. So the guanine, it is very guanine. You know what is the guanine? It is a nucleus base pair, one of. So one is a basic molecule in the DNA. That's why it is these guanine. It is enter into the DNA synthesis. Then it is enter into the cell cycle. So that here what we are doing, that the mycophenolate moftel that inhibits the inosine monophosphate dehydrogenase enzyme. It is enzyme inhibited. There is no formation of guanosine monophosphate. There is no guanine formation. There is no DNA synthesis. Then there is no cell cycle. This is the mechanism of action we have to write in the examination point. Next, when it is prescribed already, which I said that liver, kidney, and cardiac transplantation, and lupus nephritis also being the disease. This is one of inflammation in the lupus and in the nephron. During that time also we can give these mycophenolate moftel. So then come to the side effects. So same thing, and we can also give these progressive multifocal leukoencephalopathy. Also we can give this drug, and one more drug is mizoribin. This is obtained from a Upencilium brefidianum. So these mechanism monophosphate is the active metabolite, inhibit the inosine. Same mechanism of action what we discussed the mycophenolate moftel. So same the mechanism action, inhibit the inosine monophosphate dehydrogenase enzyme. Then come to the leflunomide. So these drugs, it is administration as a tablet, so that is oral. So 10, 20, and 100 mz is available. So description is a pyrimidine synthesis inhibitor. So how it is inhibited, dihydrotate dehydrogenase inhibitor. So this one also one enzyme. That enzyme it is involved in the T cells and B cells proliferation. So that is the mechanism of action. Let's just what we discussed about mycophenolate mechanism. So dihydrogenase dehydrogenase it will inhibit the enzyme, so that when it is enzyme inhibited there is no formation of guanine. So that is the mechanism of action of leflunomide. And so this is iridium monophosphate. And so it is used in so this is a leflunomide. This is the drug is a leflunomide. When it is inhibit the dehydrogenase enzyme it inhibited. So when it is enzyme inhibited, it inhibit the uridine monophosphate. So uridine monophosphate is converted into uridine. That is the mechanism action of leflunomide. Same like that, how the guanosine monophosphate, how it is the synthesis process it is happening. Same like that, uridine monophosphate synthesis process, it will inhibit. So the leflunomide inhibit the, this is the diagrammatic representation. Just you have to leflunomide inhibit the what I given here, the dihydro or rotate dehydrogenase inhibitor. So when it is inhibited, there is no formation of uridine monophosphate. When there is uridine monophosphate synthesis not happen, there is no formation of uridine. You know what is the uridine? Uridine is the one of the basic nucleus molecule in the DNA. Next to Muramonab CD3, this is monoclonal. This is a monoclonal antibody against CD3 component of a T cell receptor signal transductions complex. So it inhibits the T cells receptor activation or T cell transduction process. So mechanism monoclonal immunoglobulin G2 antibody binds to the T cell receptor CD3 on the surface of the circulating T cells, interfering with the receptor antigen interaction. So it inhibits the receptor antigen interaction. So the T cells are always maximum to bind to the antigens. Then after that binding, then the T cells produces the further action. Either it is it will kill or so let's see what is happening. So as a result of resulting transient activation of T cells, release of cytokines and blocking of T cells proliferation and differentiation. So when the antigen bind to the T cells, it is the T cells are proliferated or differentiated or to produce the cytokines. But here what happening, the monoclonal, so that is Muromonab CD3, it is a monoclonal antibody. It's inhibit the interaction between the, it inhibits the interaction between the antigen and antigen and T cells. So T cells function usually return to the normal with approximately 48 hours of the discontinuation of therapy. So when it is when it is inhibited the T cells, then after 48 hours again it will come to the normal process of the T cells. So this is the process how the already we discussed the entire this already mechanism of action. Here the again maybe it is given the, so the antigen presenting cell, it's bind to the T cells. So this is T cell surface. So like this is a monoclonal almidimuzab. This one it is the T cell, it's bind to the T cell surface. So so because of this, there is no binding of interleukins. There is no binding of antigen. Okay. So hope I think understand. So prescribed for mainly renal and heart and liver transplantation, and side effects severe cytokine release syndrome and a pulmonary edema, acute renal final gastrointestinal disturbances, changes in central nervous system. So what's this monoclonal antibody? Mainly to inhibit the interaction between the antigen and the T cell. That very important, that you don't forget. That is the mechanism of action of this immunomonab So that's it. It inhibit the receptor signal transaction complex. So that resulting transition of activation T cells, release of these are all not happening when ఏం జరగవు. అందుకే ఇక్కడ మ్యాప్ ఏవైనా కానీ సో దిస్ వన్ డయాగ్రామ్ రిప్రజెంటేషన్ ఓన్లీ. సో ఈ ట్రాన్సాక్షన్ ప్రాసెస్ అంతా ఏం జరగదు when the T cells when it is these monoclonal antibody bind here because of the antigen not bind here. So same like that, Ali alimtuzumab, so human as a monoclonal antibody, CD52 and 25. This is protein. So binds to the CD52 and of all on B and T cells, most monocyte macrophage and natural killer cells, causing cell lysis and prolonged depletion. So this one also bind to the B cells and T cells, and it is mainly to causing this cell lysis. So prescribed for what we discussed earlier in last video, what is the CLL and the CTCL, and T cell lymphoma, and side effects are hypotension, fever, shortness of breath, and bronchospasm, chills, and rashes. Rituximab. This is also one of monoclonal antibody against membrane spanning four domain protein, binds to the CD20 and B cells, mediate B cell lysis. So these antibody causes B cell lysis. And the last time the azitumumab causes the both the T cells and the B cells cell lysis. So it is bind to the it is bind to the CD5, CD52. It's bind to CD52. The CD52 protein present on all B and T cells. When it is binded, it lysis happen. Same like that, the rituximab bind to the B cells of the CD20 protein. B cells of the CD20 protein. Then after that, B cells lysis. Okay, this is a diagrammatic representation when the B cells, this is CD20, this is CD20, when it is binded rituximab, cell lysis happen, same like that. So these are all some antibodies when it is binded cell lysis happen. This is one of diagrammatic representation. So like that also CD50, what you discussed, that is a CD52. CD52 also, when it is binded, CD52 is some. Suppose if you like this, take this CD52. So these suppose the drug binded here, the cell lysis happen. So like diagrammatic representation, how it is. So rituximab, it is prescribed only lymphoma, leukemia, rheumatoid arthritis, and other renal transplantation. Okay. So autoimmune hemolytic anemia, and side effects of these is infusion reaction, hypersensitivity reactions, and tumor lysis syndrome. Okay, acute renal failure, and daclizumab, the brand name is Ginapax. We can observe here. And the mechanism of action is this one also monoclonal antibody binds to and block the interleukin 2 receptor. So that is it block the interleukin 2 receptor bind with a high affinity to the. So because of this T cells depletion them and inhibiting the interleukin 2 induced T cell activation. So interleukin through interleukin dwara T cells activation jaragadu. So daclizumab, that is the mechanism action of daclizumab. First, what I given the diagram and first signal and second signal and third signal in the given in only in one slide. That diagram is very important. We have to understand the interleukin 2. That's why I given one question: what is the function of the interleukin 2 in the last video? That is very important. So how these interleukin 2 receptor? So this is protein. These drug, it is binded and it inhibit the T cell activation through the interleukin receptor. So daclizumab also prescribed for renal cardiac transplantation. It is a side effects. These are all. And beta beltacept. Beltacept, it is a protein combining B7 binding portion of the CTLA4 with the immunoglobulin Fc region. So binds to F7, B7, sorry, it binds to the B7 and T cells, preventing the CD8 signaling and signal 2. So here the already we discussed about what is the signal 2. Just you go through another my second video regarding immunosuppressants. So it stopped the signal to, so there is no process, further process of activation of T cell activation. Okay. So about accept this one also one drug, a second generation of Bala. This is same what we discuss about accept. This is second generation of Bala. So same mechanism of action. Next, come to the polyclonal antibody. The mechanism of action of a polyclonal antibody is it contains antibodies. So it is more number of antibodies. Earlier we discussed the monoclonal antibody. Only one antibody. It is specifically bound to the one only. It's bound to the one protein, then either it inhibit the T cell activation or to lysis, either to lysis the B cells or T cells. That is the mechanism of action. Here this is the polyclonal. So more antibodies. So these more antibodies of T cell antigens including CD2 and CD3 and CD4, CD8 and CD11 and CD18 effectively depletes the T cell concentration in the body through the complete dependent cytolysis and cell mediated opsonization. So whatever the CD cells is there nothing but a T cells. Wherever it is in present in the body, it will bind and it will lysis. So these polyclonal antibodies to lysis the all T cells maximum whatever the distributor. So that's why following the T cell clearance from the circulation by the reticuloendothelial system. You know, already you studied human anatomy, physiology, the reticuloendothelial system. It is one of system to clear the all depletion of proteins or cell immunitated cells or whatever the proteins. So these mechanism of action is polyclonal antibodies is to clear the all T cells in the body. How? To bind to the CD2, CD3, CD4, CD8, whatever the T cells again classified CD4 and CD8 I said. CD4 and CD8. So whatever the CD4 and CD8 cells subclass is the CD2 and CD3, it bind all T cells and lysis takes place. When it is a lysis takes place, there is no T cells, there is no T cells, there is no immunity. So that is the polyclonal antibody mechanism of action. And these are the side effects leukopenia and serum sickness and thrombocytopenia, pruritus of fever. Just you go through once all side effects of immunosuppressants. You write it first common side effects. When you write common side effects, you can write for all. So that is very easy for all immunosuppressant drugs. So these are all. I cannot. Once again, I cannot here. Already we discussed the flow chart. This is an antigen presenting cell. This is first signal. This is second signal, and already we discussed in the first video only, first video or second video. Just you go through it. This one also we discussed about already. So suppose this is antigen bind to the T cell receptor, then activated calcineurin. Then after that, dephosphorylation of nuclear factor activated T cell and interleukin gene promotion. Then interleukin 2 production, interleukin bind to the interleukin receptor, progression of the cell cycle. This is the flow chart, very important. This is should be in your mind always. For you have to write the for any immunosuppressant drugs. If you write these flow chart, you can write it. Suppose if you're writing the sirolimus stress mechanism of action, you write entire these things. Just you mention that this is sirolimus stress. That's enough for the writing the mechanism of action. Suppose if you take in agitioprine, so you have to write here. That's it. So that's I am inhibiting the purine synthesis. So this is the flowchart, and go through what earlier we discussed. The diagrams very important, and flowchart is very important. You keep it in mind, and where it is targeted. The drug is where it is targeted. Just you have to remember that, and then it is easy for you have to write any immunosuppressant drugs. We have to remember the where it is inhibited. That's all. And side effects maximum 50% similar, 50% similar. Just you write a common side effects, then it is easy for you. Minimum the side effects is thrombocytopenia and rashes and intestinal diseases. These are all very common. Okay. And some immunosuppressants commonly used in for maintenance therapy. Suppose in liver, especially in type of transplantation. So especially cyclosporin, we can use these transplantation and zero sandy mu. And then these the especially here the brand name is changed. Nothing more on that. Then such a just only here the brand name is changed because of some brand names produces very effectively. So that's the same only, but it is one more brand. And tacrolimus, it is given to the kidney, liver, and heart. Uh, so this is a small effects. And sirolimus, it is given in the kidney. First, we can prefer the kidney, few more heart and lung. And azithromycin is a kidney, micro. Once we already discussed already when we have to prescribe this. Okay. To treat a transplantation rejection already we given this classification already. Side effects, immunosuppressants. These are the common side effects. Again, why you have to make a little bit confused. That's why I given it. So rashes. This is for all immunosuppressant side effects. It's common side effects. Common side effects. That is nausea, vomiting, diarrhea, and malaise. So not feeling well, liver inflammation, and this is for up to these very common nausea, vomiting, diarrhea, rashes, and malaise and liver inflammation is very, but these are very rare. Rarely we can observe thrombocytopenia, bone marrow depression, fever, and inflammation of the pancreas. So these are we can observe this. So but we have to write. So we can write any immunosuppressant of these side effects. So these are the last week questions. So what I given. So again I can give these some few more questions. Okay, students. So these are the questions. This session. Mechanism action of mycophenolate meflotil as a flowchart. Mechanism action of azithromycin and mesoripin as a flowchart. Left node mechanism of action. Rituximab, belatacept mechanism of action. Mechanism of polyclonal antibodies, and all immunosuppressant side effects. Common side here you have to write the common side effects. Write all immunosuppressant mechanism of action in a table. I given a table. So you make it all mechanism of action in a table. So these are the questions. All of you submitted what I given the time and the day. Thank you, one and all.